இப்போ ஒன்றும் பேச வேண்டாம் சார், கரெக்டா 3 o'clock ஆரம்பிச்சுக்கலாம். ஓகே சார். சார் ஹலோ சார். ஹலோ
ஓகே
சார், லைவ் போறோம். 3 o'clock பேசினா போதும். லிங்க் கொஞ்சம் மாறிடுச்சு. நான் லிங்க் அனுப்புறேன் சார், அது கொஞ்சம் எல்லாருக்கும் ஷேர் பண்ணிருங்க.
லிங்க் மாறிய போச்சா? இது இவர் லிங்க் தானே?
தரேன் சார், தரேன் சார், நான் தரேன். ஒரே நிமிஷம். இது இல்ல, ஜூம் இல்ல, உங்களுக்கு யூடியூப் லிங்க் தரேன்.
யூடியூப்லயா?
Very good evening to you all. On behalf of our Chief Medical Officer, Dr. Narendran sir, and our Senior Medical Officer, Dr. Kalpana madam, I extend a warm welcome to you who have all connected through YouTube. This program, a webinar on refraction for postgraduates, which is a part 2 version, is going to concentrate on higher order aberrations biometry, challenging situations, and special contact lenses. You may remember earlier in the first part, we spoke about basic refraction, retinoscopy, and basic contact lenses, and pediatric refraction. So this will be little high tech on various aspects of higher order aberrations and so on. In the panel today, we have Professor V.R. Vijayaraghavan, who has close to over 5 decades of teaching experience, is an expert in all subjects. He is a teacher of teachers of teachers. 3 generations he has seen. So he will be there in the expert panel, along with Dr. Shivakumar, who is a very senior ophthalmologist from Aravinda Hospital, Tirunelveli, is an expert in IOL refractive surgeries. On the host side, we have 4 talks today. One is by Dr. Navaneet, who is a medical officer, senior medical officer in IOL department of Aravinda Hospital, Coimbatore. The second talk would be by Dr. First talk will be by Dr. Arjun, who will be talking on higher order aberrations. He is a cornea consultant. The second talk would be on biometry by Dr. Navaneet from IOL department. Dr. Srinila will be talking about challenging situations in refraction. And finally, Dr. Devi Rosette, who's in charge of the contact lens clinic at Aravind Coimbatore, will be talking about special contact lenses. Now hand over the mic to Dr. Vijayaraghavan sir to take the program forward. Thank you very much once again to all of you. I'm sorry about the link. There was a small technical glitch, so we had to give you the new link for YouTube. Thank you so much. Sir, over to you, sir.
Thank you, Chandrasekhar. Okay, thank you, Chandrasekhar. Because
yes, sir,
I got the privilege of taking this. Thank you. Now everyone knows about lower order aberrations like astigmatism, myopia, and all, and which can easily be corrected. Now the higher order aberrations we have got like spherical and chromatic aberrations and all, coma, trefoil and all, something difficult to correct. Of course, the incidence is very minimal only, around 15%, whereas the lower order aberrations about 85%. So naturally, the correction, refraction corrections and all mainly depend mainly for the lower order aberrations. But the higher order aberrations will affect our quality of vision. That's why to overcome that, Dr. Arjun is there. He will give his opinion about higher order aberrations, how to correct everything. So Dr. Arjun is here. Arjun? Yes, Arjun?
Yes, sir. முன்னாடி போக வேண்டாம் கிளிக் ஆகிட்டு இருக்கு Good afternoon, everyone. This is my humble attempt to convince you in a topic aptly named higher order aberrations, because high order of confusion can be created by this. So this is another way of seeing refraction and optics. Mostly from childhood, we know light as a ray and we draw it as a ray. So to understand light as we go on to our college or schools level, it changes from a ray to a wave. Light is actually an electromagnetic wave. To understand higher order aberrations, you need to understand what aberrations are. To understand aberrations, better understood that light is a ray and it is a property of the ray that is used to define these problems. So this is an electromagnetic wave. So if it's a wave, there will be crescents and troughs, and if you connect all the crescents together which are in phase, then you will get a plane. That plane is known as the wavefront. But this is better represented in sound. If you think about a chorus of people who are singing, and if everyone is singing the same note at the same time, then they are all in phase. So that is an ideal situation. And if you connect all those which are in phase, then that is the ideal wavefront. So we have parallel rays which are coming, and all the rays are getting focused at a single point. And if you take all the points which are at phase and connect, then you will get a curve which is the ideal wavefront, which is not possible. All optical systems have aberrations. So the lines will get focused at different points, and because it's getting focused at different points, the wavefront will be different from that of an ideal. So we'll come to the situation. Here, the red represents the ideal wavefront and the blue represents the aberrated. Some of the waves will be ahead of the ideal one, some of them will be a little behind the ideal one. That is how aberrations work. To understand aberration, I'll take the simplest and the commonest example, which is a spherical aberration. Here we have rays which are at the which are passing through a lens. Some rays are at the center, the paraxial rays, and then there are at the peripheral. So if in a situation if it were ideal, all of them should have focused at the same point. In this situation, the peripheral rays are getting focused ahead of the central rays. That situation in which they are all getting focused at the same axis but at different locations is known as a spherical aberrations. I'm trying to convince you with the physics behind it, but let me see. Why does this happen? So if you see an optical system, we have a lens through which light rays are passing. At the center, the rays are almost perpendicular to the lens. At the periphery, they are at an angle. And the amount of light which has to travel at the periphery through an optical system is much less. When it goes through an optical system, it slows down. So if this has to travel a little less within the optics, it will be much faster than the other rays. In other words, it will be a little bit ahead of the other rays. So it will get peripheral rays will get focused much ahead of the central rays, which has to pass through more optical system and get attenuated and come back out slowly. So in some situations, they are focused at different locations and you will get the totally aberrated wavefront. That is the wavefront aberrations or the optical aberrations. Now this is how they are created. Now we have to analyze. Until now, if you are with me, from this point, I might start losing you. To convince you, we have to analyze something. There are many methods. Known methods are Taylor, Fourier, Gantinel, and the most common one, which we study day before the exam just to write something, the Zernike's polynomials. To convince you, there is a wave and we have to mathematically represent the wave, and that has to be fed into a computer which only understands mathematics and equations. The best example is to take sound. We all are storing sound waves mathematically in your phones. In other words, there is a mathematical formula which will create a wave back as sound, and you can store it in any format. Like the earlier Taylor, Fourier, or Zernike, you can store it as WAV, MP3. These are all mathematical formulas which will represent a wave, and if you decompose that formula, it will produce the exact wave back. That is the whole idea. If you have a wavefront, there is a shape, you get a mathematical formula to decompose that wavefront into smaller wavefronts, which added together will bring you the complex wavefront. Okay. So this is the idea of wavefront aberrations. In this, you can see a composite of waves. There is a red wave, which is a composite of the blue and the green added together. Waves either constructively or destructively interfere and you get a pattern. So in other words, we are breaking down a complex wave into simpler component to understand the whole wave. So this method was devised almost 100 years ago by Zernike, which is very commonly used in optics to understand aberrations into smaller components which sum together to form the more complex wavefronts. So just to understand, this is what a Zernike polynomial will look like. The most similar thing which I can tell you is think about a periodic table in which things are arranged as per atomic numbers. Here, aberrations are arranged as per an order in which there are 0, 2, 3, 4, 5 up to actually infinity. Mostly 67 is considered. For optical and eye purpose, fifth order of aberration is more than enough. So any aberration which is more than third order is considered as higher order aberrations. And wavefront can even do our regular optics. That is, our regular optics is either myopia or astigmatism. The second order represents myopia and astigmatism. That is why it is not considered as higher order. higher order aberrations are the aberrations which you cannot correct using a regular refraction. In other words, higher order aberrations are sources of the irregular astigmatism, which we call those which you cannot correct with regular lenses. Okay. This is what I've been trying to convince you. This is a wave pattern which can be deconstructed into smaller wave patterns. When they all add together, it will produce a complex wave like this. Just remember, that is what Zernike's polynomial is, to identify and deconstruct a wavefront into smaller, easier chunks which you can understand. So, like a atomic number, Zernike's polynomials are represented as orders and frequencies. As I said, higher order aberrations are 3, 4, and 5. And within the higher order aberrations, third has two types of aberrations, which is the comma and the trefoil. Fourth has got three aberrations basically, but importantly two, spherical aberration and quadrifoil. So the frequency is, if you see this case, there are three prongs. So if you go in a circle like this gets repeated thrice. So that is why the frequency is 3, and this is in the third order, and that is why the number n. So Z3 and 3 is trefoil, in which there are three prongs, and it's in the third order. They are just representation of aberrations in orders. I'm just going through only two orders, that is third order and fourth order, and only going through one of the most commonest aberrations in that. And the third order, the most common aberration is comma, and try to convince you how a comma happens. So this is the same situation, but instead of having parallel rays, the rays are entering into eye at an angle. So the central rays will get focused on the retina. Now you think about a distant ray. The distant ray gets diverged on a different location. And if all the rays are entering at an angle, they might end up getting focused at only one side from the center. In other words, there will be a point source after which a blur will keep on happening like a tail of a comet. Comma is like a comet, one point source, and then it starts spreading away from the center. If you see, this is the point spread function. In other words, how a point will look after it goes through an optical system. If a point is not a point, then there is an aberration. So here it is getting spread as a line. If you see the simulated E, which I've rotated, you can see the E is getting spread away from the center. That was a situation where the rays were at an angle. The same situation can happen if the rays are parallel but the lens is at an angle. That also can create a comma aberration. So this is how the comma will look like in a map. There will be 2 points, and this is the 3D representation. So next I'll go to the fourth order aberration, and the most common one, which I already tried to explain to you, is a spherical aberration, in which the central and the paraxial and the peripheral rays get focused at different points. There are two situations possible. One in which the peripheral rays get focused ahead of the central. This is called as the positive spherical aberration. The next is the reverse of it, in which the central rays get focused ahead of the peripheral, which is the negative spherical aberration. So remember, these are all wavefronts and they are all three-dimensional. If you see this picture, the center is focused and the peripheral rays are still trying to focus, or they are still divergent. So this is how aberrations are represented. Now trying to understand how they are measured. So I'm going only through two of the most common methods of aberration measurement, which is Hartmann and Shack aberrometer and ray tracing. So I'll try to again convince you about how Hartmann and Shack works. So this is a system in which light is projected onto the retina, and the outgoing rays, the rays coming from the retina, is then passed through a lens system. So the light which is coming from the eye is passed through individual small lenslets and they are focused onto a point. So whatever rays came back, they are going through individual small lenses and they will be focused onto the a film. In this case, what they use is a CCD or a charge coupled device, which is what we use in a camera. So let's think about an ideal situation. If it was a perfect wave, each of these lenses will focus onto the center of that lattice. So all of them will be within the grid. But when it is aberrated, one lens will focus at one point, the other will be at another point, and so we'll know from the lattice how much the points have got spread out. And from that value, we can understand how much the aberration has happened. From those values, we can find out what is known as the root mean square, or how much individual aberrations, individual points have wavered from the center. And from that, if you put it into the Zernicke's equations, you will get a wave shape, and from that you will get the wavefront aberration. So in just to remember, finally the unit used here is RMS, that is root mean square. I'll try to convince you why we are using RMS. Let's take a situation of the first wave. Here some waves are ahead, some waves are behind. So if you add them just directly, they will negate off. It does not bring any meaning. So we will square the values and then make a square root of it. So we'll get an average of all those. In other words, statistically, all these aberrations are converted into the standard deviation of the whole system. So if we are taking a third order aberration, there will be a third order trefoil, third order comma, and if you want to know the whole total third order, individual ones are taken, which may be negative, positive, all of them are square root of it is taken, you will get a standard deviation value of that. That will be the total aberration. Just remember, it is RMS and it is microns. That is more than enough for exams. Now going on to maps. There is something which is slightly different from what you might expect in a topography. So this is one of the most common aberrometer which is used, which is the Xyway. This is a Hartmann and Shack type of aberrometer, and this is the aberration maps. And this is, as I said, the point spread function, how the point is getting spread out once the pointer source goes through an optical system. This is called as a normal band, in which all the aberration values are represented in a single graph. Now think about this map. These are all three-dimensional things. And in normal sense, in topography, you might think this is a very steep area, this is a very flat area, but in aberrations, that's the reverse. If you see, this area is where the rays have already focused and come out. That, in other words, it has already converged. And this is the area in which the rays are trying to focus, or this is where it is already myopic, and this is where it is already hyperopic. Wavefront aberration maps are reverse. If you take the dioptric value, you can see the map has changed because this is already myopic. It's already converged. The same value in dioptric terms will become the reverse color. In wavefront, blue means it is already myopic or converged. Red means it is divergent or trying to get converged. Okay. This is one patient. Just for this is a pre and post-op picture of a patient, in which you can see there is a red area here, which is elevated. In other words, that is a hypermetropic or a flattened area. And post-op, the same patient's aberration has completely come down. That flattening has gone off. This is actually one of our pterygium patients after removal of pterygium. And you can see even the quality of vision can change with a pterygium surgery. The aberrations might cause a 6'6" patient to be still unhappy. They might say, I'm not seeing. That is because they might have aberrations even with a pterygium. An optical system can have any kind of aberrations even with good visual acuity. Lastly, one more technology, that is a ray tracing. So this is one of the more commoner ones, and I'll try to convince you again. this technology actually was developed for a very different purpose. There are a lot of satellites nowadays, even there are Starlinks where are 80, 100 satellites sent for a single purpose. So they won't know where their satellite is. So what they do is they send a ray of light to the satellite. It gets reflected back onto the point. At the angle at which it is coming back, they can locate that point at which that source is coming. So this is the whole idea. You might have seen this in movies where you're trying to find a person in GPS. You know 3 towers, you know the distance from each tower, you can locate a person. So this is the same thing, this is known as triangulation. So the same principle is used in ray tracing. So what are we trying to do? We are sending a ray of light inside. The ray of light comes back. And when it comes back to the sensor, we know at what angle it came back. So the machine will project that onto that point on the retina. So the eye trace does this. It sends 64 laser beams in 4 intervals across the pupil, and then finds out where on retina these points have got focused. And from that information, it will find out what the aberration is. So this is what you see on the pupil. This is what you see inside the retina. This is a emmetropy patient, 0 sphere, and all the lines are focused at a single point. This is a patient with astigmatism. It has been spread out in a plane. And this is myopia, where everything has got completely divergent. So one more thing you have to understand about ray tracing. The other one was Hartmann and Schack, where the outgoing waves were being measured. So you have no control over how it comes back. In this, incoming waves are being measured. In other words, if a ray is going in, it will reflect from the lens surface as well as from the retina surface. So if you know how much the reflection of the retina surface is, then you can calculate your corneal aberration separately from that of your total aberration. And if you know the total and corneal aberration, you can finally find out what is the lenticular aberration. So eye trace gives you your root mean square values of the internal optics, the cornea, and the entire eye separately. So if a person has some astigmatism, but the keratometry is normal, if you do an eye trace, you can find out that the aberration inside the lens is causing the astigmatism. So few clinical situations which you can understand how aberrations influence. I think you might be able to answer most of these. So let's think about this situation. Very common, keratoconus. They have a cone. That means one point is focusing all the rays into one side, getting it diverged from the center. That is a comma. It induces a comma. So another situation you can get a comma, as I said earlier. This is a comma where everything is focused. If your lens is tilted, all the focus will be onto one side, and that will also again induce a comma. The lens tilt may be a decentered IOL, which is back sulcus, or a Marfan who has a subluxated lens. Both can induce a comma. Then if this is a topographic map of a person. Here he has undergone refractive surgery. Unfortunately for him, the ablation got decentered. That will cause again the same effect of a tilted lens, and it will induce all the rays to focus on one side of the center, causing again a coma. So this is how patients with LASIK may have good visual acuity but bad quality of vision. So another aspect of refractive surgery is this is a topographic map of a refractive surgery patient. The center has been flattened. The periphery is a little bit more steep. So here the peripheral rays will be focused ahead and the central rays will be focused even more further away. So again, what will be induced? It will induce a spherical aberration. In other words, if you go for myopia where the center is flattened, you will get a positive spherical aberration. And if you do hyperopia where the center is more steep and the central rays get focused earlier, you will get a negative spherical aberration. The same goes for the cornea, which is a prolate, where the center is more steep and the cornea will have a positive spherical aberration. And same goes for when it's flattened, it will have a negative spherical aberration. So our lens inside the eye has a negative spherical aberration. and the cornea has a positive spherical aberration. So this is also one of the reasons we select a negative spherical aberration lenses, aspheric lenses, based on how much spherical aberration the cornea has. So a spherical aberration will have one source over which another source is another point is getting focused. So this is a normal eye. A person with spherical aberration can have a glare or a glare around the original picture, or have starburst kind of appearance because of the second focus, or they might have a halo or ghost images. So these are all how the aberrations will look for the patient. So this is another situation. Here there is a cataract, and the point spread function, you can see they are getting diverged into 3 spokes. Or if a person comes and says, I can see like Mercedes-Benz sign, that means he is having a trefoil. It is getting focused into 3. A lot of people will say glare even after refractive surgery, and that is because they are having aberrations. So this is one more thing. I've skipped many things in aberrations. This picture I kept. This is a radial keratotomy in which the center is flattened. So it will have the same effect of LASIK surgery or refractive surgery where you will have spherical aberration. But one thing you have to understand about aberration is dependent on the pupil size. So once this pupil dilates, these spokes starts coming into the visual axis. And around how many spokes are there, the patient might end up having 3 or 4 other points of focuses, which will produce either a trefoil or a tetrafoil kind of aberration. So again, remember, aberrations are pupil limited, and as the pupil size decreases, aberrations can decrease to a point around 2 millimeters, where the only aberration or only thing which influences the optical system is called as diffraction limited eye. In other words, if you see through a keyhole, you will see a clear picture, but there will be small black rings around it. That is because of the diffraction.
Dr. Arjun?
Yes, sir.
Time is up. Time is up.
2 more slides, sir.
Yeah.
So this is another situation where you have a rotated toric IOL. So now we have 2 axes, splitting the whole eye into 4 quadrants like a BMW symbol. Again, you induce a quadrifoil. So if you have been very attentive, and you might be having patients like this, that after looking to the screen for a long time, your tear film starts breaking off. So this is an aberration map taken 10 seconds, 20 seconds later after keep on staring, and it will cause the tears to evaporate and induce aberrations. So I hope you'll have end of this class unless you're sleeping. So on a lighter note, in reality, if you've seen this movie called Gravity, they ended up doing one procedure for Hubble Space Telescope. The Hubble, when it was sent, had one lens which had an optical aberration, causing the image quality to come down. So they corrected it by introducing another lens with a reverse aberration, and then the optical quality improved. So aberrations are there in normal day-to-day life. It is there in optic, ophthalmology, and even in nursery rhymes. So why do stars twinkle? That is because the amount of atmosphere which passes through actually the stars are very good point sources, but when it comes to atmosphere, it gets aberrated and you feel that they are twinkling. Thank you.
Thank you, Arjun. I think he has dealt very nice. That is a difficult topic, and he's made it somewhat easier. And there are definitely this understanding higher order aberrations requires some physics knowledge. And naturally, as an ophthalmologist or something, we're supposed to know some physics. But the basic physics only can understand. The remaining things are somewhat difficult for us. But for a PG, just know this. Suppose you have got a starburst or halos. They will ask you in exams. Your answer is usually maybe spherical aberrations. When you have a coma-like problems, you think about keratoconus. Then when you have a Mercedes-Benz appearance, trefoil appearance, always remember when the pupil is very small, the aberration diffraction will be very high. That's why, in exam, we'll ask one question, the pinhole size normally is 1.2 millimeters. When you make it to 0.5 millimeter, what will happen, we'll ask you. your answer is when you make it very small, the problem of diffraction will be very high. And thank you, Arjun, again. Very nice. You enlightened us. And so many things I have learned also. Thank you very much.
Thank you, sir.
Dr. Shivakumar will take over.
So the second topic is on biometry. And we as ophthalmologists, of course, know, but patients also now know that cataract surgery is very successful and it gives a good vision. And according to me, one of the most important aspect of cataract surgery is the biometry. Because you may do a perfect surgery, but if the IOL power is wrong, you've not calculated it properly, then you are landing in a mess. The patient is dissatisfied. So now we'll have Dr. Navneet talking about biometry, giving us an overview on it.
Is my screen is visible, sir?
Yes, you can go ahead and start.
Hello, good evening all. I'm going to share an overview on biometry. Biometry is a measurement in relation to a biological structure. In practice, it is a process of measuring power of cornea and axial length and using the data to determine the IOL power. What we need basically is axial length, corneal power, and a formula to calculate. Coming to the axial length, we have ultrasound and optical methods. Ultrasound is sound-based, optical method is light-based. Principle of ultrasonic measurement of axial length is we apply electric current to a piezoelectric crystal. It vibrates, thus generates ultrasonic waves. And the sound waves reflected from the structures in the eye hit back the crystals again, causing it to vibrate, generates a current that is analyzed by the machine. And the machine is recalibrated with the sound velocity of sound, and the machine calculates the time of travel of sound. As we know the sound velocity and time of travel, we can calculate the distance traveled by the sound, that is axial length. We have contact method. Here you can see in contact method, there is a high chance of upland hitting the cornea. Thus, compression of cornea, thus underestimates the axial length. This will give a myopic surprises. So we developed, we have an immersion method. Here, to avoid compression, we use a shell, which is called Prager shell. This shell will fill the fluid into the shell, followed by immersing the probe into the fluid to measure the axial length. Here, we will avoid compression, but this requires a water bath and patient cannot fix it comfortably to the visual axis. In ultrasonic measurement, you can see we have 3 fluid media and 3 remaining all solid media, including immersion fluid, aqueous humor, and vitreous humor. When the sound enters from one media to other media, it generates a wave. Here you can see sound is entering from the posterior part of the cornea to aqueous humor to lens, lens to vitreous humor to the RCS complex. When it enters from one media to other media, it generates a wave. In ultrasonic measurements, also gives a clues about some pathologies in the back of the cornea, like retinal detachment and vitreous hemorrhage. In optical method, we use 780 nanometers of wavelength of light instead of sound waves. It works on the principle of partial coherence interferometry. Advantage is here the patient have a target to fix it, so we will calculate the visual axial length which is needed for the patient. Here there is no compression of cornea, and we measure the corneal power at the same sitting. Disadvantage is as it is light based, it cannot penetrate dense opacities. And other advantage of optical methods is as it is 780 nanometers of laser beam, it can penetrate up to Bruch's membrane and retinal pigment epithelium, whereas ultrasound waves gets reflected from the first layer of retina, that is internal limiting membrane. Here in ultrasound method, entire other retinal length is missed. In conclusion, use optical biometer whenever possible. Only in dense cataract you can make use of immersion ultrasound. Now we are done with axial length measurement. Then keratometry. Keratometry is a measure of power of cornea, but actually we measure only central 3 mm zone of cornea. We have manual, automated, and optical biometers. In regular corneas, there is negligible difference between all the keratometers, but older machines can only measure anterior corneal curvature Only newer technologies can measure posterior corneal curvature, which is important in toric IOLs, post-refractive surgeries, and keratoconus patients. Manual keratometry, Bosch and Lomb keratometer projects a first Purkinje image over the cornea, and a big circular mire is what patient sees, and 3 circular mires is what doctor sees, and which is calibrated over the both sides of the machine on the handle. Clarity of mires indicates focusing. To align horizontal meridia, we have to align plus plus. To align minus minus, which gives the power over the machine on both sides. Horizontal and vertical powers are given. If you are unable to align the plus and minus, that means there is astigmatism. We have to rotate the handle of the machine. Then we can align the plus plus and minus minus. Lens star works on the principle of low coherence optical reflectometry, can measure the cornea at 32 points, and it can measure the axial length and corneal power at the same sitting. All optical biometers can measure both at the same sitting. IOL Master 500 can measure the cornea at 6 points in hexagonal pattern from which are 2.3 mm from the center of the cornea. IOL Master 700 works on the swept source OCT, which can measure the posterior corneal astigmatism too. In conclusion, in regular corneas, use optical biometer only in keratoconus patients, post-refractive surgery patients, and toric IOL patients. Or also, we have to make use of advanced machinery like anter-segment OCT or IOL Master 700. After you measure axial length and corneal power, we have to troubleshoot it. When your axial length is less than 21 or more than 26, when your corneal power is less than 41 or more than 47, when your astigmatism is more than 2.5, our axial length difference between the both eyes is more than 0.7, our corneal power difference between both eyes is more than 0.9, you better to repeat the measurement in these cases. So now we have an axial length measured and corneal power measured. We need a IOL formula. In history, formulas started as theoretical formulas, which are based on simple geometrical optics, but there were problems. Estimated lens positions cannot be determined from preoperative anterior chamber depth, and refractive index used to estimate the corneal power from the anterior corneal curvature is just a hypothetical. And of course, shape of cornea gets altered after the surgery. So we came with regression formulas. Regression formulas are modification of formulas based on large number of post-operative refractive results. And SRK1 is the first regression formula developed. Since then, which is introduced by Sander Edgolf Kraft. Since then, many generations of theoretical and regression formulas have been introduced. And SRK-T, T means theoretical, combine both theoretical and geometrical optics, regression data. And after that, ray tracing, Vergence formulas, and recent artificial intelligence are also introduced. This is the evolution of formulas. And here we have 9 types of eyes based on anter-segment size and axial length. And these are the formulas we have available. We compared the data errors, accuracy of each formula in various ranges of axial length. Here you can see SRK-T showed significant absolute error at in shorter eyes less than 19 millimeters of axial length. It showed errors up to 2 diopters. Each formula worked better at different ranges of axial length. In conclusion, if your axial length is less than 21, go for Hoffer-Q. If it is more than 22, go for SRK-T, or use Barrett to universal or Hill-RBF formula for all ranges of axial length. Now we have IOL power calculated. We have to quality check the IOL master chart. Signal noise ratio should be more than 2, and axial length should fall within the standard deviation of 0.1, and interaxial length difference should be within 0.7, and keratometry, make sure your keratometry readings are not displaying any X dots over the chart. Coming to the special cases, as we discussed, in shorter eyes less than 22 mm, better to go for a Hoffer-Q or a Barrett universal formula. In staphylomic eyes, better to go for optical biometry as patient fixates towards a target there. In dense cataract, as we discussed, we have to go for a immersion ultrasound method. In regular astigmatism, if it is more than 0.75 diopters, it should be corrected by toric IOL. In irregular astigmatism, most devices gives inaccurate corneal reading. So solution for this is, if your maximum corneal power is more than 55, Use standard corneal reading because most devices are less repeatable and less reliable, and target for a minus 1.5 postoperative refraction. Use SRKT formula in these cases as it is most accurate and tend to have a myopic surprises which counteracts the hyperopic surprise. If your maximum corneal power is less than 55, use actual corneal reading. Still, the biometric prediction error is between -3 to +3. You should calculate anterior and posterior corneal power without any assumption and use that power in a Holiday 2 formula or a Barrett 2K formula or online calculators. In post-refractive surgery patient, we need posterior corneal curvature. We have to go for advanced machinery like IOL Master 700, as older machines cannot give posterior corneal curvature, and we have to use the value in Holiday 2 or a Barrett 2K formulas. Our calculator found in online like ASCRS or Barrett 2 suit also works good in post-refractive surgery patient. In silicon oil filled globe, as we know, sound travels slower in silicon oil. We have to reduce the speed of velocity of sound in ultrasonic methods or go for optical biometer, which is not affected by silicon oil. In macular pathologies, in like a cystoid macular edema, retinal detachment, and submacular hemorrhages, axial length is underestimated. Solution for this is we have to evaluate retina prior to the surgery. Our newer devices like IOL Master 700 gives a retinal image by which we can evaluate the macular pathologies. The last point, in cases like if you have a posterior capsular lens, when you want to shift the IOL from back to sulcus, this is a simple memorizing rule of 9. If you have a 0 to 9 diopters actual power of IOL, there is no need to change any power when you are putting in sulcus. If it is 9 to 18 diopters, subtract 0.5. If it is 18 to 27 diopters, subtract 1 diopter. If it is more than 27 diopters, subtract 1.5 diopters. Thank you.
Thank you very much, Dr. Navneet, for a very compact talk on a very complicated subject, equally complicated like aberrations. But practically, there are a few things that you should keep in mind that whatever instrument that you're using for biometry should always be calibrated regularly. There are inherent errors in various stages in the instrument itself, in the way it measures the corneal power or the way it measures your axial lens, and all these need to be taken into account. As far as the formulas are concerned,
sir, 1 minute, sir. Can Dr. Navneet close the slideshow, please?
Yeah.
Yes, sir. Yes, sir.
Thank you, sir. Sorry, please carry on.
And as far as the formulas are concerned, the refinement is still on, and initially for the theoretical and regression formulas, it was after that it was realized that what matters the most is to estimate the lens position. So estimated lens position became an important factor in the prediction of IOL power. And then we have the combination of theoretical and regression, which is generation 3. And finally, what we now use are the ray tracing or even the Vergennes formulas. They are known as the Vergennes formulas. And the most accurate are considered to be Holiday 2 and Hages. SRKT works well for normal and myopic eyes. So generally, we use SRKT and for normal and myopic eyes, and the offer Q for short eyes. But if it is available, then an optimized constant Hages A0, A1, A2, as well as Holiday 2 will work well. But the main factor why Holiday 2 is considered to be very accurate is because it not only considers the K and the axial length like the other previous formulas, but it also considers other factors like white to white, the anterior chamber depth, and the lens thickness, and even the race, as well as the age of the patient and the refractive status of the patient into account while estimating the lens position. Holiday 2, of course, is a paid formula which is available with certain instruments, or you need to pay it in order to get the this thing. But what is now available freely and which is considered to be very accurate, especially for the extreme axial lens, is the Barrett formula. The Barrett Universal 2 is supposed to be very good, and if you have this extra data like the lens thickness, white to white measurements, then you can always go online and use this formula in order to verify your IOL power that you have got through other formulas. So the refinement is still on. There are more like Kane and others. In fact, even artificial intelligence is being used where the post-operative outcomes, just like we had the regression formulas, the post-operative outcomes are recorded or shared by all the surgeons for various axial lengths and keratometry combinations. This is known as RVH, and this is artificial intelligence, which will then suggest how close to what is the predictability of your IOL power being close to emetropia or whatever refractive power you want by putting that particular lens for your particular axial length and keratometry readings that you have measured. But all said, finally, it depends upon the surgeons or the institutions actually refining their biometry methods and also looking at the results and even fine-tuning the results in order to bring more improvements in biometry. So I think this sort of shortly sums it up. Thank you.
Thank you.
Thank you, sir, Dr. Shivkumar. And a very nice presentation, Dr. Naveen. Thank you very much. Now we have got a next topic, special that is problems with challenging situations in refraction. And as for a PG, we'll ask something, like what is refraction? We'll ask you. Your answer is we have got so many methods to evaluate the status of the eye. These methods are all coming at a refraction, which was dealt by, I think, last session or something last month. I think Dr. Samshekar took about retinoscopy. There is one method of finding out the status. We have got now, when you have refraction, when you give corrections, the patient should be happy. Then only you are supposed to get next patient. Suppose the patient has got a problem with your first refraction itself, they will not come to again. So please remember one thing. Nobody will come and get the cataract surgery for you. They will not come first. First, they will assess your refraction, how you are moving and all. That's why learning refraction is a must. That's why I advise all PGs to learn at least retinoscopy personally, and don't depend on autorefractometers and all. Of course, nothing wrong, but at least learn something retinoscopy. Now we have got some special situations and problems with refraction. Dr. Srinala is going to talk about the special problems.
Thank you, sir. I thank the organization for giving me this opportunity. As sir said earlier, refraction is an art. However, giving the correct prescription to the patient is a real challenge. So today we will discuss about few situations which we face daily, how to go about them in future. So first I'll discuss few case scenarios. So a 24-year-old who's seeing reasonably well at distance is found to have minus spherical power during his subjective refraction. This is because young patients tend to use their accommodative ability much more. So when we ask the patient to look at the acuity chart, the letters on the acuity will look smaller, darker, and hence the patient feels that that is better. So the minus is given as excess due to the accommodation. So to prevent such problem, we have to instruct the patient to look at the acuity chart and compare only the clarity. And then we can do cycloplegic refraction, that is use a cycloplegic agent so that the patient cannot accommodate, and we can obtain the retinoscopy values to cross check. And then also we can fog the patient so that he doesn't use the accommodation. And in the end, when we prescribe the glasses, we have to do a red-green duochrome test. So if the refraction is proper and we are giving him the correct power, the red and the green side of the screen will appear equally clear. But if they don't appear clear, then we have either given extra plus or extra minus. So if the patient sees red red clear, then we have to give more minus. And if the patient sees green clear, then we have to give more plus power. Next, a 75-year-old patient who's found to have -1 diopter change in the refractive error when compared to his previous glasses. We should always think of myopic shift in such patients because the progression of cataract or an uncontrolled glycemic status of the eye can cause reasonable change in the refractive index. So because of which they can have a myopic shift. Even excess medications like acetazolamide or topiramide also can cause, or hyperbaric oxygen treatment also can stimulate such increase in the refractive index. Next scenario is about a 35-year-old with hyperopic correction in their glasses. He's seeing well at distance, but he's having some difficulty only while reading. This patient does have hyperopia, but he faces a situation because he's not fully corrected by glasses. So because he's not fully corrected, he's using his accommodative ability and correcting his latent hyperopia. So there is sustained and insufficient amount of accommodation for reading. Hence, he is finding difficult to read. So in such patients, again, do a cycloplegic refraction and then only give glasses. However, if you feel there is large hyperopia, then call the patient for a post-mydriatic test and only then give him full hyperopic correction if he accepts. A 20-year-old found to have hyperopia was given glasses after cycloplegic refraction, but he comes back and he says he can't tolerate his new glasses. As I said earlier, he was given a large amount of hyperopia. So significant amount of plus that was not worn earlier was prescribed to him, which was found on a cycloplegic refraction. In such cases, we have to ask the patient to come for PMT, determine how much he can tolerate. Because for long-standing accommodative tone, which has been present to self-correct the latent hyperopia, he might be resistant to a relaxation. So over time, his tone will decrease. So additional plus can be added until the full hyperopic correction is accepted. So we can't give him complete full correction immediately. He may not accept. A 60-year-old has hyperopic change in the prescription compared to his last visit. So this could be because of his hyperopic shift. It generally happens when there is macular edema or any recent initiation of treatment or treatment modality change for diabetes mellitus, because the displacement of the detached neurosensory retina or choroidal thickening can cause such hypermetropization of the eye. A 6-year-old child has refractive error of 1.25 diopter in each eye. So what about his glasses? If this patient doesn't have strabismus, then the glasses need not be given because they have ample accommodation to correct hyperopia at that age, which is invoked without the conscious effort of the patient. A 26-year-old having begun to wear new glasses. His old prescription had -1.75 diopter with a cylinder of -1 at 90 degree. He was prescribed a new PG with -2 diopter spherical power and -1.25 at 75 degree cylindrical power. The patient complains the top of the desk looks slanted. He has nausea, floor seems to be coming up at him. So here, this complaint is mainly because of the change that is made in the astigmatism correction. The astigmatic portion of the glasses is the one that is causing this difficulty. The change in cylindrical axis, especially in large power, is always a concern. So whenever we are changing the axis, a trial run should be given for the patient before you prescribe. We have to give correction in both the eyes, ask them to move around or look at straight lines to see if they are comfortable with the new axis power change. A 24-year-old myope who had small astigmatism earlier, choosing a large cylindrical power now during the subjective refraction. So in such cases, we have to rule out prescription of excess minus fear to such patient, because this will in turn increase the cylindrical power. because every half diopter X is minus given to the patient, the cylindrical power will have to be increased by 1 diopter to maintain the spherical equivalent, and also for the circle of least diffusion. A 44-year-old presents with complaints of difficulty while reading in dim light, especially at bedtime. This is because there is diminished accommodative ability because of the onset of presbyopia due to his age. So in dim illumination, the pupil dilate, so there is loss of pinhole effect of meiosis. And also the accommodation is little sluggish in the morning, and accommodation is at fatigue late at night because they're using it for the whole day. Again, reading at bed, one tends to hold the reading material closer than in a day, which will require more accommodation. So for such patients, we have to first prescribe the presbyopic glasses based on their age and their acceptance, advise them to read in a well illuminated area, and increase the illumination, hold at appropriate working distance whenever you're reading, especially in the night. So the basis for all the refraction is retinoscopy. So today we'll deal with some common problems that we face in retinoscopy. So retinoscopy is all about reflexes, the with movement, against movement, and the neutralization point. So if the reflex is dim, which is due to media opacities or small pupil or because of high metropia, then we have to do retinoscopy on dilated pupil for such patients. And we can also do off-axis retinoscopy. That is the retinoscopy that is performed with the testing eye of the examiner aligned with the non-testing eye of the patient. And we can do retinoscopy by reducing the working distance, coming closer to the patient, or because the reflex is dim, we should suspect high to moderate powered plus or minus lenses in such patients. So if again, if it is media opacities or small pupil, there is a dim reflex because reduced amount of light reaches the retina and it is returning to the retinoscope. So you can use a large aperture sight hole here, or use small number of lenses in the trial frame. And some people have the habit of adding the working distance lens into the trial frame, so you don't have to use that working distance lenses, and also you can reduce the working distance. Scissor reflex. This is two reflex which moves towards and away from each other like blades of scissor. So this is mostly seen in optical aberration, keratoconus, or corneal scarring. So here when we perform retinoscopy, we get confused regarding the reflexes. So in that case, neutralize the central band rather than the darker peripheral band, and rotate the retinoscopic beam to find the angle where the scissor reflex is the least. And also increase the room light, so the pupil side cut down the peripheral aberration because it dilates. The varying or the changing retinoscopic findings, you keep on getting different power values, then that could be because the patient has a wandering fixation. That is, we ask the patient to fix a target at a distance, but if they do not fix at the distance, then we get changing values. Or it could be because of abnormally active accommodation. So in such patients, we'll have to do cycloplegic refraction or do a fogging technique. Again, if the patient has a large pupil, then spherical aberration can provide more against movement in the periphery of the lens. It could be either positive or negative aberration. So in such cases, you concentrate only on the reflex that's there in the center, and increase the room light so that the pupil constricts and cut down the peripheral aberration. Accommodative fluctuations also occur at times. So here you will see the movement reflex and the brightness keeps on changing rapidly. So when this happens, you have to first see if the patient is correctly fixing on the target. And if reflex fluctuation do not appear and it is still there is change in the fixation, then there is no change in the fixation, but still there are changing in the reflex fluctuations, then you have to suspect latent hyperopia or pseudomyopia. And for such patients, you should perform cycloplegic refraction and then reassess the power. In strabismus, perform the retinoscopy along the patient's visual axis. Retinoscopy on the good eye is performed slightly off the axis, and for strabismus eye, change the fixation point for good eye so that the retinoscopy along the visual axis of the strabismic eye is easier. So occlude the good eye and perform the retinoscopy slightly off axis. In low vision patients, generally they have large dioptric changes. So do a static retinoscopy, that is ask the patient to look at the distance and fix a target. You can use either radical or off-axis retinoscopy. Radical retinoscopy is, we perform the retinoscopy close to the patient. We reduce the working distance. And then verify the endpoint by seeing point of reversal. That is, if it is plus power keeps on changing, we have crossed a neutralization, then it suddenly becomes myopic. Then go back to the previous power, and that will be your neutralization point. So we check for the point of reversal here, and post dilatation, cross check the retinoscopy value. And if they are below 15 years, always perform cycloplegic refraction. So after the refraction is done, we have prescribed the glasses. Many of them come back with intolerance to spectacles. So this could be because of improper frame selection, because each shape of the face has different type of frames that suit better, and they accept that kind of frames better. And lens fitting is very important, because the pupillary alignment and the fitting plane of the lens should be perpendicular to the visual axis, and the type of lens that they use also should be considered. And we have to make sure that the prescription is right. We have not given a wrong prescription to the patient. And anisometropia, if the difference between the two eyes is more than 2.5 diopters, then we should make sure that they do not have any diplopic symptoms when they are issuing. If they do have like that, then we have to undercorrect such patients. Then high refractive errors, they can have peripheral margins or distortions, and also have restrictions in the field. And organic disease like diabetes and other macular disorders can involve the spectacle changes. And heterophoria, again, based on the type of squinting, we have to decide on how much correction we are going to give. So lens defect could be from the optical lab itself. That is, there could be change in the lens thickness, the stress lines, distortions, aberrations, or poor polishing or unwanted prisms present in the lens. Or it could be a fitting defect, that is the decentering or incorrect lens power, scratches or inaccurate axis, or segment height variations, or lens chips at the edges, fitting gaps, or long lenses. And frame defects could be poor facial wrap, an incorrect vertex distance, bridge size, temple length, earpiece, or pantoscopic tilt, and very occasionally the style. The pantoscopic tilt is the inward tilting of the spectacle with consideration of the facial plane to increase the field of view. So why is it very important to measure an interpupillary distance? Because failure to measure the pupillary distance accurately will result in the misplacement of the optical center of lens. That's what we call as decentering. So this will induce the prismatic effect, and this will require the wearer to turn the eyes inward or outward in order to avoid diplopia. So this constant action can create a visual discomfort and asthenopia to the patient. And vertex distance is the distance from the back of the surface of spectacle lens to the front surface of the cornea. So a plus lens, when moved towards the eye, will lose the perceived power, or moved away from the eye will gain perceived power. A minus lens moved towards the eye gains perceived power, and moved away from the eye will lose perceived power. So Dondo's rule has to be followed when we give correction for excess near work patients. So it is a scientific method for near vision correction. Here we have to calculate what is the available power, then calculate what power is needed for the patient, keep 1/3 of the reserve, and then give the required power. So a watch mechanic reads at 67 centimeter, but he needs to read at 25. So the available power for near vision at 67 is 1.5 diopters, and the power needed at 25 will be 4. So if we keep 1/3 reserve of the available power, that will be 0.5 minus from the 1.5. So he will have 1 diopter. So this we have to minus from the required power, that is 4 minus 1, we get 3 diopters, and hence we have to prescribe this power to the patient. So after the glasses are prescribed, if the patient feels the distance vision is blurred, incorrect prescription or incorrect axis, or the segment height could be too high, or near vision, the segment height could be too low, or it could be an incorrect prescription. If the patient sees the wave in distance vision, then it could be an axis change. If they feel that their head tilt forward for the distance, then the height fit height is too low, or for near and intermediate distance he feels better with the head tilt forward, it means there is incorrect prescription. So any sort of problem with the spectacles, always check the lens material, verify the centration, and check the surface defects, and then reassure patient. Thank you, sir.
Thank you, Dr. Srinala. You have done very nicely about refraction corrections and all. And for postgraduates, they must know what is she already told about decentrations. When you have a decentration from the optical center shifted somewhere, you get a prismatic effect there. And you're supposed to know here about the Prentice rule. And the second thing she was telling about the low vision corrections and all. And here they will ask you the definition of low vision. Your answer should be best correct visual acuity less than 6/18 up to 3/60. Up to 3 bases called low visions. Then she mentioned about the scientific correction, the Donald's rule and all, scientific correction of presbyopia, nicely mentioned. Then another point she already told, a small boy coming with some of the powers, suppose +1 or 0.5, better avoid prescribing the lenses because child normally is born with hypermetropes, and gradually the power is coming down, maybe reach normal 0 by the age of 12, 13. That's why if a child comes with a 0.5 and all, don't prescribe unless the power has got very high or the child has got a squint to try that. Next, you have got whenever a patient, another point I want to tell you, whenever a patient comes to you, they got a 6/6 vision is there. Don't send him out. He is not a normal person. You must always rule or must do what is called fogging method. You put a +4, the vision is whatever things are little bit blurred. Then put a +3, then +2, +3, like that. That means what? You have to start from +4, then 3, 2, 1, and 0. That means all the time the letter should be blurred. Suppose the patient tells you he can see very well the last line, 6/6, with a +3, +2. That means he has used his accommodation to correct that +2. That is called manifest hypermetropia. Always remember, whenever you see a patient with 6/6, never forget to do fogging method to rule out the manifest hypermetropia. These are the common questions in examination. You must do all these things. Then another thing she told about cylindrical corrections. My advice is whenever suppose patient has been wearing 180 degrees cylinder minus or something.
Can you close slide share, please? Please close slide share.
Minus
sir, sorry,
180. Okay. Minus 180 or degree patient has been using for the past many years. And you're done retinoscopy. The patient has got about 150. Don't prescribe. Be careful because the patient might not accept. So best option is same prescription you give it, and then that is the same angle. You can access, you can give and send him out. So normally, suddenly we jump and suddenly prescribe a cylinder for high power that access and all for high cylinder. Better avoid. These are all the things, and everything nicely spoken by Dr. Srinala. Thank you, Srinala. Thank you. Next, she's coming, huh? Now we have got a topic, the contact lenses, which was dealt last time. And now we have got special situations or special contact lenses going to be given by Dr. Devi Rosette, going to give a talk on special contact lenses. Dr. Devi Rosette, please.
Thank you, sir. Good evening, everybody.
The next topic is on special contact lenses. I'm going to discuss about the lenses which are used for astigmatism, presbyopia, irregular corneas, therapeutic contact lenses, and orthokeratology. So first, coming to the contact lenses which are used for astigmatisms, the lenses which we use are soft toric contact lenses, rigid gas permeable contact lenses, hybrid contact lenses, and scleral contact lenses. I'll discuss in detail about the soft toric contact lenses. So these lenses are basically soft lenses which have different power in different meridians. The surface could be either, the surface is classified into front toric, back toric, and bitoric. The astigmatism, the cylindrical power is incorporated in the front surface in front toric, back surface in back toric, and bitoric it is incorporated both in the anterior and the posterior surface. Materials could be either hydrogel or silicon hydrogel. Wearing schedule includes daily disposable, monthly, and yearly. So what are the indications? Soft toric lenses can be given both for regular and astigmatism, but the range is limited. You can give up to -6 diopters of cylinder. So how are these lenses different from soft spherical contact lenses? The toric lens has to align its cylinder axis with the axis of the astigmatic error. To achieve stabilization, there are various techniques incorporated by the different companies. The techniques available are prism ballast, truncations, double slab off, accelerated stabilization design, and reverse prism design. Let's see each in detail. Coming to prism ballast, here prism is incorporated into the inferior part of the lens, which causes the lens to be thicker there. So the thinner edge of the lens comes and aligns beneath the upper eyelid. So this is sometimes this thicker part will cause this inconvenience to the patient. So the newer designs doesn't incorporate prisms, but they actually cause variation in the thickness of the lenses at different sites. In truncation, no prism is incorporated. The lower portion of lens is cut horizontally. In double slab off, the thin zones are present the superior and the inferior part of the contact lenses. Accelerated stabilization design, you have thicker areas in the mid periphery, where this part of the lens doesn't come in interaction with the lids. The thinner parts are present at the upper and the lower edges of the lens. And another one method is reverse prism design. Here the prism is not incorporated in the center part of the lens, but is incorporated in the peripheral part of the lens. And since it is in the periphery, to avoid thickness of the peripheral part of the lens, chamfering of the lens edges is also done. So how do you identify these lenses? These lenses will have scribe marks. Different companies incorporate different techniques. Scribe marks, in some lenses, the scribe marks are at 6 and 12. Some lenses are only at 6 o'clock. Some lenses have 3 laser lines at 5, 6, and 7 o'clock with 30-degree interval. And even some lenses have marks at 3, 6, and 9 o'clock. The 6 o'clock mark is thicker. So what are the parameters available? Base curve ranges from 8.5, 8.6 to 8.9. And the diameter is usually 14 mm to 14.5 mm. Power, you have spherical powers ranging from -20 to +20. And the cylindrical power ranges till 2.25 in the monthly types. And the yearly types, you can even go up to -6 diopter of cylinder. So basically, how are these toric soft contact lens fitting is different from the soft spherical lens. Yeah, these lenses has to maintain the rotational stability. Even if the lenses rotates after a blink or gaze, it has to come and sit in the same position, same axis where it was intended. So the orientation of the axis should be stable. So what is more important is the ideal fit will have the same features as that of soft spherical lenses, like full corneal coverage, good centration and movement. Along with that, you have to see that even after mislocation, the lens has to return to the original axis of astigmatism. So the one thumb rule to be known in soft contact lens, soft auric contact lens fitting is Lars or Kaas rule. Both mean the same. If the lens rotates to the left, you add, or clockwise, you add how many degrees the lens is rotating, you have to add it to the original prescription. If it rotates to the right, you have to subtract the amount of degrees the line has rotated. So after this, let's see what are the lenses which are used for presbyopia. These are called multifocal contact lenses. These are also available in soft material, rigid gas permeable materials, and hybrid lenses. Basically, the design of the multifocal contact lenses is different from the routine spherical contact lenses. So here it is the designs which we use are alternating image or translating design and simultaneous design. Simultaneous design includes diffractive, aspheric, and translating. So coming to translating design, the lens looks like this, with the distance part incorporated in the superior part of the lens, and the inferior part contains the near vision. And it is again here also you don't need any rotation, so it is again flattened inferiorly. So these lenses will provide clear visual acuity at distance and near. But if there is any undue lens movement or rotation, again the vision is going to be blurred, and you'll have image jump because of gross variation in the powers in the lenses, and it is not very comfortable like use the bifocal glasses. And then coming to the simultaneous designs, these designs are available in both soft and RGB materials. Distance and near correction both are present within the pupil. So these designs work better in larger pupils, and it is actually light dependent and not gaze dependent. And these lenses are easier to fit. So these are the designs that are in use now. Concentric, you have the distance power typically in the center of the lens, surrounded by concentric rings of near and distance. Even center near design is also available. In aspheric, the distance power is in the center with a gradual transition to the other powers as you move away from the center. The most commonly followed design is the diffractive zone. You have various concentric rings with different powers. So this lenses covers for almost all distances. So what are the parameters available? Base curve is and diameter is the basic 8.6 and 14 mm. And the power ranges for spherical distance, you have -9 to +9. And here you have basically two types, low add and high add. Up to plus 1.5 diopter of presbyopia, you advise low add. And beyond that, you give high add. The bearing modalities available are daily, disposable, and monthly. So one more point to be aware of about these multifocal contact lenses is monovision. Here in this, reading power is incorporated in the non-dominant eye. There are basically three types of monovision: conventional, enhanced, and modified. In conventional monovision, the dominant eye is corrected for distance, and the non-dominant eye is corrected for near. Enhanced monovision, the dominant eye is corrected for distance, but you use a bifocal lens for the non-dominant eye. In modified monovision, you use bifocals for both the eyes, but you correct the dominant eye for a better distance vision and non-dominant eye for the better near vision. So the most important key factor for success of monovision fitting is you have to correctly identify the dominant and non-dominant eye. And you don't achieve success in all cases of multifocal contact lenses. Unsuccessful fit is very common with multifocal contact lenses. You can expect unsuccessful fit in cases of high myopes and high astigmatism with flat corneas, dry eyes, lower lid laxity, because lid tonus should be very good to maintain the multifocal lenses in the center, and any cases of external ocular disease. So what are the drawbacks? The most important point is the optimal fit. Only if you have optimal fit, the lens will be centered on the visual axis, and at the same time you should have adequate movement. They'll have patients using multifocal contact lenses find difficult to adjust because the viewing experience will be different. And during the adjustment period, initial period, because of those rings, they'll have nighttime glare, and it is also expensive.
So coming to the next topic, contact lenses for irregular corneas. So basically, I've outlined the most common lenses that we use for irregular corneas: rigid gas permeable lenses, Rosquet lenses, and scleral lenses. We have already discussed about the rigid gas permeable lenses in the last class, but I'll just touch upon the salient features alone. Basically, RGPs are used for high astigmats and with irregular astigmatism, like patients with keratoconus, patients with narrow palpebral fissure. And the physiology of RGP lenses is better comparatively to the soft contact lenses, and it is also deposit resistant. So what are the parameters available? Diameter range is 8 mm to 10 mm, and the material is fluorosiloxane acrylate. And these are multi-curve lens with flat peripheral curves. The power, it comes in both low, high, plus and minus powers. And the base curve ranges from 5.5 to 8.6. So this is the picture showing the ideal fit. As previously discussed, these lens should center within the limbus, and the corneal about 1 to 2 mm, it should be centered within 1 to 2 mm of the corneal limbus. And you have to assess the dynamic fit. That is, you assess the movement of the lens with blink, and then you assess the static fit by putting fluorescein. In this picture, you see that in the central part of the lens is having a feather touch, and there is a mid-peripheral bearing, and there is moderate peripheral clearance. This is the central part, and this is the mid-peripheral part having bearing, and this is the peripheral part with clearance. And above all, patient should be comfortable with the fit. So next is Rosquet lenses. These lenses were introduced by Dr. Paul Rose of New Zealand. These lenses have complex computer-generated peripheral curves, and curves. The optic zone diameter decreases as the base curve steepens. And they also have aberration control, aspheric optics. And they have standard flat steep peripheral systems to achieve the ideal edge lift of 0.8 mm. And this is the basic principle of Rosquet lenses. Here in the first picture, you see in a steep cornea, if the optic zone is small, you have a area where the tear film can pool and it can cause compression on the cornea. Whereas in this case, whenever the cornea becomes steeper, when you reduce the optic zone, the lens actually drapes over the irregular cornea. So the base curves available are 4.75 to 8 mm, diameters from 7.9 to 10.2, and they also have additional advanced fitting options like toric peripheral curves and asymmetric corneal technology. There are 4 types of trials available in Rosquet lenses. Rosquet 2 for the mild to moderate keratoconus, Rosquet 2 NC for the nipple cones, and Rosquet 2 IC for advanced keratoconus, and also for keratoglobus, and Rosquet 2 PG for post-graft patients. So let us see in detail about the scleral lenses. So how are these lenses different from the RGPs? They are also made up of RGP material, but they are completely supported by the sclera, and it achieves complete clearance over the cornea and limbus. Actually, the lens walls over the irregular or diseased ocular surface. The lens traps a reservoir of fluid, that is the unpreserved saline, hydrating the cornea and corrects the irregular astigmatism. The lens, it has only limited movement, and there is less lens awareness. So there are 4 types of scleral lenses based upon the diameter of the lenses. Cornea scleral lenses range up from 12.9 to 13.5 mm. Semi-scleral lenses range up to 14.9 mm. Mini-scleral lenses range from 15 to 18 mm. And full scleral lenses range from 18.1 to 24 mm. So what are the indications? Basically, to correct vision and to protect the ocular surface. Vision correction in cases of corneal ectasias, which may be primary or secondary. Primary includes, you have keratoconus, keratoglobus, PMD. Secondary includes post-LASIK ectasia, and in cases of post-keratoplasty astigmatism, any scarred irregular corneas post-trauma can be fitted with the scleral lenses. And then to protect the ocular surface in cases of SJS, graft versus host disease, OCP, neurotrophic keratitis, Sjogren's disease, and persistent epithelial defects. So coming to the contraindications, they are contraindicated when there is a lower endothelial cell count of the range of 600 to 800 cells per millimeter square. In cases of uncontrolled glaucoma, blebs which are overhanging the cornea, and patients having handling issues. So there are 3 zones in the lenses: optic zone, transitional or intermediate zone, and haptic or landing zone. Optic zone houses the optical power of the lens, and the transitional or intermediate zone controls the sagittal depth, and haptic or landing zone lands on the conjunctiva, and it actually supports the weight of the device. So this image shows the centrally this blue part, thick dark blue part shows the optic zone, which has the power of the lens, and this is the transitional zone, and finally you have the landing zone, that is haptic zone. So what does these scleral lenses do? They achieve an even bearing on the sclera to avoid compression of blood vessels, and you have a diagnostic set of trial lenses to determine the correct sagittal depth. After you find the final optimal fit, you do the over refraction to get the correct lens bar, and they have back surface peripheral curve system modifications are available with these lenses. So you need special devices for inserting these lenses. This first picture shows this plunger. After you insert the lens, immediately you look for bubbles, and if there are any bubbles, you have to immediately remove the lens, again reinsert the lens, and when as soon as you insert the lens, you check for the vault in the slit lamp. If there is a touch, immediately go for a higher sag. If the sag is too high, if you feel if it's too high, you can go for a lesser sag. So how do you assess the scleral lens fit? You assess the vault, scleral landing, centration, and movement. Centration is, as previously mentioned, it should cover the cornea all around at more than 2 mm, and the movement should be very minimal. It should not be very tight, but there should be some minimal movement. The key points are the vault and the scleral land. Vault, you have to check the central, mid-peripheral, and limbal vault. So coming to vault is you measure the distance between the posterior surface of the lens and the anterior corneal surface. You have to check with white light, and the reference for the thickness is the corneal or the lens thickness. And the central vault should be ideally between 100 to 200 microns. And the mid-peripheral or the limbal vault should be around 50 to 100. It usually tapers from the center with no touch. There should not be any touch of the lens over the cornea up till the limbus. And then how do you assess the scleral landing? It should be aligned. The lens should align over the sclera. And if there is any pairing, you will have either blanching, compression, impingement. And if it is not aligned, if it's lifting over from the edge, you will see air bubbles getting inside the lens. You won't see air bubbles as soon as you insert, but you will find air bubbles after some time entering from the periphery of the lens. This is an ASOCT picture which shows the aligned scleral lenses. So this picture, you can see there is blanching of the vessels in the first picture, and here there is compression of the blood vessels. So what are the advantages? You have better centration and stability than the corneal lenses. These are comfortable as these lenses rest on the conjunctiva, as it is less sensitive than cornea. Disadvantages: these lenses are very expensive, fitting is time consuming, and you need a special applicator saline solution for these lenses, and you have a complication of midday fogging, that is debris gets collected in the reservoir, and there are more chances for front surface deposit, and even chronic hypoxia when you use for longer hours, they may end up with corneal neovascularization, loss of corneal transparency, and LSCD. So let me share with you a video of scleral contact lens fitting. First, you have to take the lens, place in your arm, and then in your hand, in the palm of your hand, and use a multi-purpose solution to rub and rinse the lens. Once that is done, you take the plunger, place the lens at the center of the plunger, Okay, the lens should be centered on the plunger. Okay, then you fill the lens with the unpreserved saline and then use a fluorescent strip to stain the saline. Then you should ask the patient to look down. The head should be parallel to the ground, and you keep the lens over the eye and release the plunger. And then immediately you check for air bubbles and or if there is any touch. Then how do you remove the lens? To remove the lens, you place the plunger at the edge of the lens, and with the suction, you remove the lenses. So, having seen about the scleral contact lenses, let us see about therapeutic contact lenses. We can use both soft contact lenses and scleral contact lenses for therapeutic purpose. Basically, they are used for protection in case of entropion trichiasis or exposed suture knot, pain relief in cases of corneal erosion, bullous keratopathy, filamentary keratitis, post-surgery like PRK and C3R. In corneal erosion, the most important point to keep in mind is you have to wait for the epithelial adhesion complex to form for a period of you have to maintain the lens for a period of 2 months till the epithelial adhesion complex forms well. And then you can use it for promoting healing in case of neurotrophic keratitis, persistent epithelial defects. I mean, cases of very small corneal perforation, you can use these lenses for sealing the perforation. So basically, they are made up of silicone hydrogel material, and they have low water content, which prevents dehydration of the lens over the eye, and they should be of low modulus. Higher modulus lenses are stiffer, so it will cause discomfort to the patient. The diameter is you have a wide range of diameter ranging from 14 mm to 20 mm. The power is usually plano, and the fit should be optimal. It should not be steep or flat. Steeper lenses will be tighter and it will cause more discomfort. Flatter lenses will be more mobile and it doesn't serve the purpose. So for bandage contact lenses, you have to schedule frequent follow-ups. You have to explain the potential complications to the patient. Risk of infection is important. So you have to call the patient for frequent follow-ups. So next is on orthokeratology. This technique is basically to reshape the cornea. It's a non-surgical topographical approach to eliminate refractive correction. It is a temporary correction of low to moderate myopia. The lenses are actually reverse geometry lenses with high decay, and they are indicated for overnight wear. So this is the morphology of the lens. You see the central treatment zone. This has the flatter base curve, and then you have the return zone, which is a bit steeper than the treatment zone, and then the landing zone, which rests on the cornea, and finally you have a edge, posterior edge ellipse. So the mechanism of these lenses is they flatter central fitting will result in applanating force on the cornea, causing the flattening of the corneal epithelial cells. So advantages is the lenses, the effect is reversible and both eyes are altered at the same time, and there is no disruption of vision during treatment and no pain compared with the PRK, and you can discontinue treatment whenever necessary, and it is an option for children. Disadvantages, it is not a permanent solution. Amount of refractive error correctable is limited, and non-compliance is expected, and risk of infection because of overnight wear should be kept in mind. Thank you.
Thank you, Dr. David. A very nice presentation of contact lenses that took for the special occasions. And one, yes, actually it said that rigid contact lenses are better compared to soft lenses. The reason is the durability as well as the maintenance. Because the soft contact lenses notorious to produce infections, and the most common bacteria you can expect is Pseudomonas. That is why better option, if possible, rigid contact lenses. Otherwise, better for the patient comfort, you can go for a soft contact lens, but with advice of maintenance of the lenses to be proper. Next important point for exam purpose is, when you have a rigid contact lens, you put a fluorescein to assess the fitness. The fitting, whether it's fitting is properly or not. That means you have fitted the lenses properly or not. Whereas in the soft contact lenses, better not to put fluorescein so that they can absorb the fluorescein, and the soft contact lenses you cannot assess easily. The problem will be there for the patient. Then another thing, the hot contact lens, they will ask you why it's not used nowadays. Your answer is hot contact lens will not allow the oxygen to enter the cornea. So naturally, they will have the edema of the cornea, which is called Sattler wheel. It's a short note for you, Sattler's wheel. Then as far as she told about monovision bifocal glasses, for that matter, of course, not bifocal contact lenses to multifocal lenses and all. But if you're asked about the bifocals for a presbyopia, that is, they will ask you, myopia patients, what bifocal is preferable? Your answer should be flat top, like the bifocals are better. For a hypermetropia, you got round top, like cryptoc, KRY, the cryptoc is preferable. The reason is the optical center of the upper portion and the lower portions, they can be very close, thereby the image displacement when the patient is down is minimized. There's an advantage of prescribing myopia patients flat top and hypermetropy patients round top. And of course, she told everything about rigid lenses and rose scale lenses. My advice to the students, better read about fitting of for the keratoconus patients, a common question. And I once again thank Dr. Devi for the nice presentation. Thank you, Devi.
Thank you, sir.
Yes, sir. I think we are out of time. I should thank all the 4 speakers for giving elaborate talk on difficult topics, higher order aberrations, biometry, challenging situations, and special contact lenses. I'm sure it will be useful for all the postgraduates, and good interaction from Dr. Vijayaraghavan sir and Dr. Shivakumar sir. And I should say that these YouTubes, this one and the refraction part 1, will be available in YouTube. So anybody can watch it anytime. There'll be good tools, and all these points covered are all useful for your exams for all postgraduates. I'd like to thank Dr. Vijayaraghavan sir and Dr. Shivakumar sir and all the speakers for a wonderful program. And I'd like to thank the management for giving us an opportunity to hold this 3rd part. We are planning on the refraction part 3, which will give an overview of surgical and laser procedures for refraction from PG's point of view. We are not going to go into the smaller aspects, only the broad classifications, how is the principal, major complications, and so on. So that should be somewhere next year. So I'd like to thank all of you who are online and thank the faculty for this wonderful presentation. Thank you so much, all of you.
Thank you, Dr.
Thank you,
Chandrasekhar. Thank you. Thank you very much.
Thank you very much, sir.
yes, sir.
Opportunity.
You can stop screen live streaming, please.
Leave meeting for a while.